So, South Africa is participating in the Public Health Emergency Solidarity Trial that has been initiated by the World Health Organization to conduct a clinical trial to find effective treatment for COVID-19. Now, the South African Solidarity Research Team is led by Professors Helen Rees and Jeremy Nell, working with 30 senior academics, researchers and clinicians from 8 medical schools in the country. Now, Professor Helen Rees joins us now live via Skype on the agenda to tell us more. Hey, Prof, thank you very much indeed for your time. Appreciate it, especially during this difficult time, uncertain time in South Africa.
Yes, I agree. Very uncertain.
So the WHO convened an independent group of experts to review evidence from laboratory, animal and clinical studies to prioritize treatments for inclusion in the trial. I see they've come up with a number of treatment options for this trial. Some of these names I can't even pronounce. I'll let the experts like yourself tell us more about it. What are these options, Prof?
Well, what the World Health Organization has done is that it's looked at previous outbreaks of other coronaviruses and has looked for products that might have shown promise then. So SARS and MERS, which people will have heard of. And so they've pulled out some products that either in the laboratory or in animal studies or in clinical care looked very promising in that setting. So there's a combination of antivirals, including things we're very familiar with in South Africa, antiretrovirals, drugs that historically have been used to treat and prevent malaria, other drugs that are used for what we call autoimmune diseases and some cancers. And so there are 4 different drug interventions. There's also one new antiviral, brand new antiviral that has been developed in the US that will also be added. So this is a complex study in the sense that it's going to have 5 different arms, but 4 of them will have different therapeutic options that we will be evaluating in the study.
So, US President Donald Trump recently touted the common malaria treatments, hydroxychloroquine and chloroquine, as potential game changers. Reportedly, some scientists have lamented his embrace of these drugs. What's your take, Professor? Are they potential remedies for COVID-19?
Well, this will be one that we're evaluating, but I think what people who understand clinical trials, and I also have a regulatory hat with the South African Health Products Regulatory Authority, we've got glimmers of hope for all of these 4 products. And that's why we put them in the trial, because we think there's a chance that one or more of them might well be effective. But unless you do a proper clinical trial that's properly conducted, you will never be able to answer that. And the problem is then you can be throwing lots of treatments at people, not knowing whether anything works. And you said just now in your piece that 80% of people have mild disease will get better. Even people in hospital, the majority, even if they have more severe disease, the majority of people will recover and get better.
Right.
So what you won't know if you don't do proper studies is whether what you're looking at is somebody who was going to get better anyway, or whether your drug really helped. The important thing about this particular study, and it's incredible the amount of support that the academic institutions around the country have given to this study. But the important thing is that we're one of now, I think, about 70 countries worldwide. There are already about 10 countries that have started. Norway has started now, Spain. So many countries are participating. And the good thing about this, the more countries that participate, the quicker we can do this. The quicker we will be able to identify which drugs work and which drugs don't. So just back to your question about chloroquine. It's one of the drugs we're looking at. There are suggestions that this might help, but we really don't know. And it's quite a potent drug. And it has quite a lot of different effects on the immune system. So it would be really premature. And I think President Trump's own scientists told him this. Don't jump the gun. This is far too premature. We need to understand much more about what really works. Because we don't want to do harm, and we don't want to do nothing when we treat people. We want to find the things that work.
Because when you mention these drugs publicly, it tends to be in high demand. It flies off the shelf. And it limits the amount of drugs that are available for people that actually really need it. Because chloroquine, for instance, is used for other ailments, isn't it?
That's quite right. And in fact, there is now a world, exactly because of that and because of some of the comments that have been made in the media, there's now a real shortage of chloroquine. We will be able to get chloroquine for our study and all the other products in the study. Remember, there are a number of other products that also potentially could have an impact. We will be getting those directly from the World Health Organization.
Yeah, look, it needs to be, I guess, a all hands on deck scenario here in order to get to where we want to be in terms of finding this vaccine. Other countries that have already confirmed their participation in the trial include Argentina, Bahrain, Canada, I understand France, Iran, Norway, Spain, Switzerland, Thailand. So a lot of countries coming together in order to find a solution here. Realistically, though, Professor, how far out are we from getting a vaccine for COVID-19?
Well, a vaccine is probably the most complicated thing that we want to develop. But I'm with another global organization, and in January of this year, before we had seen what we call human-to-human transmission, when we saw this signal coming out of China, we immediately mobilized funds to invest in vaccine development. So this has been going on very seriously since January. And you probably heard that there's been what we call one of the early parts of clinical development, the phase 1 trial, that has started in the United States with one of these products. But there are about 40 vaccines now in development. I think that some of them, I'm pretty confident that not all will work. But I'm pretty confident that some will be developed. But you have to first do these early trials to see if they're safe and to work out what kind of dose you need to give to get that immune response that could protect somebody. Yeah. Then you have to move on to larger numbers of people and look in more depth at the immune response and different populations of people. And finally, we will be rolling out these vaccines to hundreds of thousands, tens of thousands of people. To see whether the vaccine works. Yeah. I think that we do believe, even if we get through this first part, this virus is likely to be with us for a long time to come. And in the medium and long term, we need a vaccine. That's probably at the earliest to get a vaccine through that clinical trial process and manufactured and available. At the earliest, we're probably looking at 18 months, I would think.
18 months at the very earliest. And that's consistent from the many experts that we've been hearing in terms of, look, in order to get a vaccine that is safe and effective, it needs to take time. You can't just put something out there that can adversely affect the population. Many, Professor, in South Africa are asking if the 21-day lockdown will be enough. Will it be extended? I was listening to Dr. Anthony Fauci, who you will know very well, but just for the viewers who don't, he's the director of the National Institute for Allergy and Infectious Disease in the United States. And he was talking about, the uncertainty in America and the anxiousness that people are feeling. And he was saying people there need to be realistic. They need to understand that we as people don't make the timeline here. The virus makes the timeline. Do you agree? Absolutely. I mean, much as we'd all like to wave a wand and say, this amount of lockdown is all that's required, we don't know that. And as you know, the president announced this intensive, growing testing campaign. All of us, I think, in the scientific, the clinical world, the epidemiological, public health world in this country would agree that what we have to do now is to get out there and test. Yeah. But the way to really slow this down, and we must try and slow it down, is to do this distancing, is if you can stay in your homes, to stay in your homes, and to, if you have symptoms, to quickly isolate yourself and present for treatment. That will slow things down, and we have to slow things down. Otherwise, our numbers could go up extremely quickly. Yeah. Deaths could go up very, very quickly. And to pull back from that would be very hard. And this is what the president was talking about yesterday. We need to take this disease seriously. Many are not in South Africa with regards to this lockdown. You reckon we can cope with regards to the increase in testing? Already we've done over 38,000 tests and confirmed 1,326 cases of COVID-19 in South Africa. We're told that this will need to increase exponentially every day. Can we cope? Can South Africa cope with regards to the amount of testing that needs to be done?
Well, I think one of the commonest expressions you'll hear people who are in the planning in South Africa saying is, we're building this plane while we're flying it. So we are pushing from the SAPRA, the regulatory authority, the NICD, the laboratory side. We're looking as rapidly as we can to find rapid tests that are going to be extremely important a bit later on in the outbreak. These are tests that can be done quickly, and they show us whether there are antibodies. That shows us whether the person has already had an infection that they might well have cleared. Yeah. It'll give us a really good mapping of what's happening with the infection. But at the same time, we're trying to get in more machines, more reagents. The NHLS is rolling out mobile testing sites so that we can also identify those acute infections. These are people in the community who've got symptoms and are confirmed to have the infection. And for those people, we need to be able to quarantine and isolate them, to monitor their very close family and contacts, and to do contact tracing. So all of this, there's an intense effort to do this. And you heard from the president that we're going to have door-to-door in our most vulnerable communities. We'll start there. But I think the other side of this, and we can't say this enough, the government can't do all of this by itself. The public sector's come to the party. That's brilliant. But it's actually us as individual citizens. We need to not only protect ourselves, but if you protect yourself, if you think about it, you're protecting your family. If you take no notice of the instructions and you bring that virus into your home, you don't know if it might be your mother, your auntie, your grandmother. It might be your brother or your wife or your husband who's got diabetes. What does that mean? You might be fit and well. You might get through this, but you're going to bring that virus into another group of people. This is truly a global effort across the country that we have to all commit to. And it's not something we can just put out there to government and say, you government, you do it. We have to take responsibility.
100%. Look, Professor, we're fast running out of time. I want to try to keep you here a little bit longer. We need to go for a quick break to get to the top of the hour. But I just want to get this. Look, we're learning more and more about this virus every day. Scientists are learning more and more about it every day. And the new thing now, well, the talk really now is about how long this virus stays in the air. Can we get it via transmission via the air? Is it airborne? Initially, we were told that this virus spreads via respiratory droplets. So somebody needs to sneeze or cough. If you're in close proximity to them, you'll get it. If you touch a surface where the droplets land, you can get it. But, we were told that it doesn't hang in the air for a long enough period for somebody to get, infected. Has that changed? Is there new data out with regards to transmission via the air?
Well, this is being looked at all the time. The predominant way that this virus spreads is just as you said. And that's why we're saying to people, keep those 2 meters apart. Because, you know yourself, sometimes we speak and we see little bits of spit. It's just life. It comes out of our mouths. And then, of course, we cough and we touch and we touch our faces on average more than 20 times every hour. So all of us touch our faces. It's what we do, and we don't even think about it. So, and if we've got that droplet, we touch our face, then it can go into the respiratory tract or into the eyes. That is the common way, and that's why we're saying keep that 2 meters. That distancing is incredibly important. Now, we do know that under some certain circumstances in some of our intensive care environments, there is a chance that this can be that you can get more virus into the air. But at the moment, that's not seen as the common way, the likely way that this is going to be spread. It is going to be droplet spread. It's about surfaces and washing your hands and washing your faces and keeping distance to people.
Right. Professor, if you don't mind, I want to keep you a little longer. There's so much to discuss. People are sitting at home now, wanting to know more and more about this virus, COVID-19, novel coronavirus. I want to take a quick break and get some headlines at the top of the hour. If you don't mind, please stay with us. We'll come back to you in a short while. That's Professor Helen Rees there, an expert in this field. So she's explaining, in terms of what can we expect going forward.